I want to welcome everyone back to the PTAC public meeting. I'm Paul Casal. I'm Vice Chair of PTAC. So we will now continue our discussion on care coordination in the context of APMs and physician-focused payment models. Over the years, as PTAC reviewed proposed models that stakeholders have sent in, we noticed that care coordination emerged as a theme, in part because integration and care coordination is one of the Secretary's 10 regulatory criteria for reviewing physician-focused payment models. In fact, most proposals submitted to PTAC included at least one care coordination function, as Lee and the PCDT pointed out in their presentation earlier today. We've invited several previous submitters of these proposals to join us today for our second panel discussion. As Jeff said this morning, this is not a re-deliberation of their proposals, but a chance to learn even more from the field about the role of care coordination in alternative payment models. Our panelists' full biographies, as well as their organization's proposals and the documents related to PTAC's review of those proposals, they all can be found on the ASPE PTAC website. So I'm going to briefly introduce our guests and their current organizations. First, we have Sherry Erickson from the American College of Physicians and Christina Borden from the National Committee for Quality Assurance. ACP and NCQA partnered together to submit a proposal last year. Next, we have Kate Freeman, representing the American Academy of Family Physicians. Dr. Narayana Murali from Marshfield Clinic Health System, and Kendall Haygood from Contessa Health. They're representing the proposal from Personalized Recovery Care. Dr. Susan Nedza from Health Policy Insights is representing the American College of Emergency Physicians. And finally, Dr. Joe Rotella joins us from the American Academy of Hospice and Palliative Care. So you can see we have a great panel and some different care settings and proposals represented. We have several questions for our panel. And so in the interest of time, for some of the questions, I'll begin by inviting 2 or 3 of the panelists to respond. Then I'll open it up to committee members to ask any follow-up questions that they may have. So I ask each of our panelists to try to keep their responses to a few minutes and look forward to a robust conversation. So first, would each of you please provide a brief description of how care coordination was incorporated into your proposed physician-focused model? And I'll cue each of you for this one. So we're going to start with Joe.
Okay, thank you. AAHPM's model, which we call Patient and Caregiver Support for Serious Illness, addresses the gaps in Medicare coverage for community-based palliative care for patients with serious illness. That is, patients with potentially life-limiting medical conditions associated with decreased function who are at increased risk for potentially preventable ED or hospital visits, particularly those who are not thought to be in the last 6 months of life and therefore not eligible for hospice care, or who don't choose hospice. Under our model, community-based interdisciplinary teams would be paid to furnish high-quality palliative care, starting with a comprehensive assessment of the patient's needs, goals, and preferences, and development of an individualized care plan centered on what matters most to the patient. Interdisciplinary palliative care teams have special expertise in discussing goals of care, relieving pain and symptoms, and providing emotional and spiritual support to improve the quality of life for people with serious illness. Disciplines represented on the palliative care team may include physicians, nurses, social workers, spiritual care providers, nurse practitioners, physician assistants, pharmacists, counselors, and more. Care coordination is a foundational element of palliative care, integrating not only the patient's concerns and the assessments and interventions of palliative care team members, but also input from all of the patient's other physicians and healthcare teams to create an integrated and individualized care plan that's updated whenever there's a significant change in the patient's circumstances. This includes arranging for services from other professionals and teams and communicating with them on an ongoing basis to ensure that all aspects of the patient's care are aligned and consistent with the care plan. Our paradigm of care coordination goes well beyond the traditional focus on a patient's medical needs and engagement with other physicians. We take a holistic, comprehensive, person-centered approach and also address a patient's psychological, social, spiritual, cultural, financial, and practical needs and concerns. In addition, we engage a broader circle of partners in their care, including caregivers, family members, and community supports. The palliative care team practices active care coordination to prevent disruptions in care and maintain the well-being of their seriously ill patients. That requires that they be accessible on a 24/7 basis. And you know, that crisis call they get at midnight may be triggered just as easily by an overwhelmed and exhausted caregiver as by a new medical complication. And that's why the interdisciplinary, holistic approach of palliative care, addressing not just medical, but also social and other determinants of health, is so essential for getting the best outcomes and delivering value for this population. Thank you.
Thanks, Joe. I'm going to turn to Sherry.
Hi, yes, thank you. Do you hear an echo from me, or is that?
No, I think you sound fine.
I heard one for a moment. Thank you, and I want to thank you for inviting both ACP as well as NCQA to share our views on the importance of care coordination and alternative payment models and how our medical neighborhood model would be able to demonstrate mechanisms for ensuring effective and efficient care coordination, particularly between primary care and specialty practices. This is critically important given that the visits to specialty care clinicians account for more than half of outpatient visits in the U.S., and referral rates are increasing over time. Mutually respectful interclinician relationships are required for effective collaboration, and this is something that we have built directly into our model. Participating specialty practices must meet consensus-based standards to improve care coordination and advance care delivery, and incorporate a pre-screening process for all visits to ensure that patient visits are maximized. From the patient's perspective, they work with the primary care practice first to agree that a specialty referral is appropriate. The primary care practice then refers the patient to a participating specialty practice. The specialty practice will pre-screen the referral request and accompanying documentation to ensure it has all the information it needs and that scheduling a specialty visit is the most appropriate next step for the patient. Then during the patient's visit, the specialty practice would establish a care plan with the patient and referring primary care practice and enter into a care coordination agreement that would be between the primary care practice and that specialty practice. And that agreement would be, and the care plan would be based on the needs of the patient and in consultation with that referring clinician. The specialist may be actively involved in the care and then would be designated as either the patient's principal co-manager along with the referring primary care practice or as the primary manager of the patient's care for the referred condition. The designation along with the completed office visit would trigger an active phase of attribution under the model, which would commence model payments to that specialty practice. Automated triggers would be in place based on visit frequency to determine if the specialty practice is taking on a less active role over time, which would then unattribute the patient to that practice and cease the model payment. However, reattribution could occur at any time based on the patient needs. I believe that this approach layers in the patient needs as well as the expertise of that specialty practice and that of the primary care practice to ensure the most effective and efficient care coordination for that patient across the continuum of their care. Thank you.
That's great. Thanks, Sherry. Kate?
Hi, and thank you all so much for inviting us to be here and talk about our Advanced Primary Care Alternative Payment Model, or as we like to call it, the APCAPM, because we need more acronyms in healthcare. So the AAP submitted this proposal to the PTAC back in 2018, and it was really an envisionment of moving further away from fee-for-service than CPC and CPC plus, the models being tested by CMMI. We really viewed those models at the evolution of this model as allowing practices to deliver care in a more innovative way with less restrictions, reducing administrative burden, and really focusing on delivering the right care to the right patient at the right time. The other piece of this model, we really wanted to focus on increasing the investment in primary care and focusing on the long-term ROI that these types of models and care coordination can really show, which is something that the recent National Academies of Science report really focused on as well. So I think, in terms of care coordination, in comparison to CPC plus, we really focused on not requiring a reporting burden, which a lot of the CMMI models do for care delivery, and really focusing on attestation, understanding that care delivery in all of these practices really looks very different, but allowing those practices to really have the flexibility to meet the needs of their patient population. The other thing we really thought was important, especially as we're making models that are available to a variety of practice sizes and segments of employed versus solo independent, those types of things, is that there's really a need for technical assistance for those practices to make the transition to understand how this different type of payment can help them deliver care in a way that's more effective for their patient population. So I think, highlighting that decreasing burden, providing technical assistance, increasing that investment to primary care really provides a foundation to move practices away from fee-for-service and really deliver the type of care delivery that's beneficial for health outcomes, improving quality, and reducing costs.
Great. Thanks, Kate. Narayana?
Yeah, so our model was really focused on providing hospital care at home, and our care coordination piece, as well as all the elements related to that, were significantly strengthened by the input of the PTAC committee when we had brought this as our initial proposal. It's a multidisciplinary team. It includes not just the primary care physician or the hospitalist, but also the specialists, the mid-level practitioners, the pharmacists, the nurses, the social workers, the physical and occupational therapists, as well as home health resources. Central to the whole dimension is the presence of care coordinator. The care coordinator assumes two roles. One as a physical care coordinator who's involved in engaging with the patient when the patient comes into the emergency room, identifying the eligibility criteria, assuring that that patient can be screened and managed very well, meeting the necessary criteria. And then over an entire acute phase as well as the 30-day period, a combination of the physical plus a virtual care coordinator who manages the entire episode of care over a 30-day period. The model is designed around risk payment and is very effective. Now, when the patient comes into the ER, after the screening criteria is met, basically confirming that the patient is not in a critical situation that requires ICU care or ventilation, or does not be in a SNF criteria, which is very important from the standpoint of whether we should be providing that care at home, and finally, whether they have adequate home support from the members of the family are the determining criteria. Once that is done, there's coordination from the standpoint of all of the durable medical equipment, the home care elements, the telehealth elements, where you basically have a kit in a box, infusion, all of the treatment elements that are covered by the, and then there's logistics related to the same piece, and it's all managed. We have continuous feedback back to the primary care provider through the telehealth and the telemetry technology, and that acute care period spreads over a duration of between 3 and 7 days. Once the patient is discharged from the acute care, we continue to manage the entire episode of care for 30 days, coordinate that in terms of scheduling post visits with the primary care physician, their own primary care physician, providing them a discharge summary, giving them all the necessary information at the conclusion of the episode. So the telehealth technology empowers it and is necessary from that standpoint. From a social work standpoint, because the nurse is actually visiting the home, providing the care at home, you're very close to all the elements that are required from the standpoint of the social determinants of health, and we're able to put in all the necessary that are required from the standpoint of care coordination. In fact, the entire model of hospital at home is centered around care coordination.
That's great. Great. Thank you. And then turning to Susan.
Let me begin by saying thank you for the invitation, and also thank you to the current and former PTAC staff who did an amazing job of helping us through the process and helping us to understand, based on their knowledge and also the knowledge of some of the other models we're hearing about today, how we could improve the model that we were proposing. It is called the Acute Unscheduled Care Model. For those that like acronyms, it's awesome. And that was probably the biggest contribution I made to the project. Just kidding. I had the opportunity to serve as the principal investigator for the data that was used upon which we deliberated, and was joined by a number of other experts from emergency medicine, mainly who were involved not only in health policy, but also were in practice. So I would like to describe the model by using a scenario, if I may. And that was the scenario of an 84-year-old female comes in at 2 o'clock in the morning on a Friday night after experiencing some abdominal pain. There's a workup completed. During that care process, staff asked, is it safe for you to go home? Is there anybody home? Do you live alone? Do you have stairs to negotiate? Do you have a ride to the doctor's appointment the next day? The physician becomes made aware of those particular items of interest. Physician also discusses with the patient and with the patient's family the opportunity to go home as opposed to being admitted. It's important to know there really are no financial benefits for emergency physicians to discharge patients at this point. It's also in the hospital's financial interest to admit patients. So in order to ensure that we have the ability to provide a safe discharge for patients, that requires care coordination. So I've pointed out the care coordination during the episode of care, but the second point of care coordination is at the point of discharge disposition. This is the most expensive decision we make as emergency physicians: admit, transfer, observe, or discharge. And it is also the point where we are most likely to have an interaction with family and undertake shared decision making. In the past, what would have happened, at least in my practice, is I would have called the primary care physician, spoke about whether or not they could re-examine the patient next day, or if potentially they wanted to refer them to a surgeon for an exam, or if they wanted to come back the next day for an exam. That would have been decided between the clinicians who had been involved in the patient's care, and then adequate arrangements would have been made by our discharge nurses. This is before care coordinators. We know how to coordinate care in the emergency department. We know what we need to do during episodes. The model was built based on the current practice and processes, so we weren't disrupting or creating anything new. We were just including incentives and measures such as including shared decision making, a safe discharge assessment, a conversation with the follow-up primary care provider or their other person that might be covering for them. And then finally, to ensure that the discharging physician, who's now accountable for that decision, makes the best possible decision with the patient, with their family, and with whoever's going to follow up with them. The model is then designed to reimburse emergency physicians for those activities, for care coordination, for taking part in shared decision making, and for reviewing safe discharge and participating in safe discharge assessments. None of these were developed de novo. They came from other models that CMMI has instituted and that are, if you consider, good practice, best practice for discharging patients from the hospital in general. So we really felt that this model was where we wanted to focus. And as we go through some of the other questions I hope we'll receive, I'll provide more details. But that's the core of the model. Thanks.
Thank you. That's great, Susan. So I appreciate the overview from all the panelists. Very helpful. I think next we're going to dig a little deeper. So what specific functions or activities related to care coordination are the most important for improving quality and reducing costs in APMs and physician-focused payment models? And how might these functions vary by context or setting, or for different patient populations? So for this, we're going to start with Sherry.
Great, thank you. There's a lot I could say about this question. I'm going to keep it as brief as I can and then also ask Christina to supplement what I say about this. So our medical neighborhood model is not limited to any one clinical condition, so it can be effectively implemented for multiple patient populations. It's designed to provide effective and efficient care coordination for all patients that have a need to have their care shared by a primary care practice with a specialty practice, whether that be for the short term or over a longer term basis. I think as the COVID-19 pandemic has demonstrated, pure fee-for-service models lead to significant financial problems for many practices and serve to exacerbate the already challenging health disparities and access issues that many in our population face. So an APM such as the medical neighborhood model offers the opportunity for practices to be supported in providing coordinated care to all of their patients who need specialty services, whether that's in person or, quite frankly, via telehealth, which has grown so much over the past year. While the model is perhaps most applicable to patients who require management of their chronic conditions, the standards that the specialty practices would be required to meet will also facilitate improved access and care for patients with acute care issues. And additionally, a critical component of our medical neighborhood model is the use of the care coordination agreements that are put in place between the primary care and the specialty care practices. I mentioned that earlier. These lay the groundwork for how patient care will be shared between these practices and can be updated over time based on the needs of the patients that are shared between that practice. So I'm going to turn it over to Christina so that she could touch on some of the relevant standards that these practices need to meet in order to be effective specialty care practices that share the care with the primary care practice.
Thanks, Sherry. And so, as Sherry mentioned, really the standards that we've developed help primary care and specialty care work hand in hand, and so that neither one feels like a lone iceberg in the ocean floating away. And so the standards that provide the support for the care coordination functions, in addition to the care coordination agreements, other things like improving clinical access and expanding access to timely care, including providing same-day appointments based off of urgency, electronic access to the patient's information, and we've definitely seen, the importance of this as we've integrated telehealth and more and more. Having a standardized process for closing the referral loop so that once an important referral goes out, that we know that that has been taken care of and that referral loop has been closed. Tracking and coordinating care across all settings, providing culturally and linguistically appropriate services, really focusing on a team-based approach so that all know what kind of care needs to be given and that it's coordinated to the highest level. Identifying and coordinating patient populations using electronic systems to monitor clinical data and implementing evidence-based reminders and decision supports, and planning and managing care that includes medication management, support for patients, self-care, and electronic prescribing. And also just wanted to note that not just large integrated systems have demonstrated effectively executing these care coordinated functions and standards in the medical home neighborhood model, but also many small practices and a variety of specialties have achieved PCSP recognition, demonstrating the applicability and success across the different sizes and types of practices. Thank you.
Great, thanks, Christina. We're going to turn to Susan.
Thanks, Paul. I think the most important focus for care coordination in the model that we've developed is that discharge disposition period of time. And it's the problem that's been identified from the first report to err as human through quality chasm. There's a chasm between emergency department discharge and the next person seeing the patient. that was discussed in this morning's panel, and I think a number of people spoke very eloquently to the issue of the lack of information and often unfortunate consequences with ED dispositions. It's designed to make that handoff and to coordinate that handoff in such a way that the emergency department becomes an integrated part of the care delivery system, as well as provide services that make us part of the solution and not the problem. Many of the models look at avoiding ED care as part of their goal, and that's appropriate for certain populations. But acute unscheduled care, especially in the Medicare and Medicaid populations, will continue to occur. And this care coordination recognizes the fact that that will continue to occur and also allows flexibility to put in place care coordination models dependent on the context of the facility. What's pretty unique is the fact that we are very much dependent, and our decisions are dependent on, and always have been dependent on, social determinants of health. Do people live alone? Do they have a ride? Do they have family? What are the potential patient safety hazards in their home? That's been part of our practice for years in deciding whether or not to discharge patients. This care coordination model is designed to help fill those gaps in some of the areas that we heard from Sherry, as well as to ensure that there is information transfer between the emergency department and the follow-up primary care providers or specialists while we wait for interoperability to occur. As I demonstrated or spoke of earlier, we used to do this by telephone. We can still do it by telephone. It would be better if we had medical records that translated. And one of the things that we discovered when we built the model is that 5% of ED visits happen out of state. Medicare recipients do not stay home. They travel. They go to Florida for half of the year. So the idea of being able to provide some type of connected service to a provider in that community was also included in the model.
Great. Thanks, Susan. Narayana?
Yeah, Paul, would you mind repeating your question? Because I think you hit two specific elements, and I just want to touch on them.
Absolutely. So the first part is, what specific functions or activities related to care coordination are the most important for improving quality and reducing costs in APMs and physician-focused payment models? And the second part is, how might these functions vary by context or setting or for different patient populations?
All right, so I will take the second question first. In the situation of hospital at home, we pretty much take care of any patient who meets the criteria of being admitted into the hospital, except if they need to be intubated, they're hypoxic or have hypotension, and the physician does not think it is safe to move that patient outside the ICU care. So I think from the standpoint of the DRGs, we have over 150 DRGs in which we provide care. So it provides the complete breadth and depth of care. To give that in a story, I will share the story of a 93-year-old gentleman who was admitted to the hospital at home with severe heart failure, as well as severe chronic obstructive pulmonary disease, who we admitted at the home hospital in addition to getting the rehabilitation, both physical and occupational elements, to provide his care. So there was a cardiologist involved in his care, diuretics that were given by IV, oxygen that was arranged for his COPD, in addition to his nebulizers, and all the necessary physical therapy to get this gentleman functional. Approximately a week or so into his care, his health deteriorated, and he made a decision that he would prefer to go down a palliative arrangements, and we ran into a snafu. He was too sick to go into a home hospice program. He was too sick to be provided care for in a nursing home program. So we elected to use all of our support networks from the care coordination to basically provide him coverage for that duration of time till he passed away, much to the liking of his family. I think the proof of the pudding lies in really tasting, and I think that is demonstrated in the studies that we have done, comparing patients who are hospitalized to patients who were hospitalized at home, the patient satisfaction subsequent to the care coordination after a 30-day episode was 90+%. Our safety outcomes were phenomenal. We had scores of 100% in terms of functional status assessments, as well as 0% in terms of fall, 100% in terms of medication reconciliation, and a 44% reduction in readmissions to the hospital. It just tells you can be and is critical from that standpoint. So then what are the elements that are really relevant to make this better in terms of quality and value? I think there are three challenges. The number one challenge is really the interoperability of electronic health records in the resident health systems. Presently in the nation, there are over 350 hospitals that do hospital at home. We were among the first 9 that instituted this during the COVID pandemic. And in the interoperability, we have bypassed that by using a care document that is available in a PDF format in each resident health institution so that that can be easily identified and available. We have provided access for the care coordinator to read the EMR and all the orders so that they can read them and verbally communicate and make sure that over the entire episode of 30 days, that is taken care of. So that's one critical element. Interoperability is important, not absolutely necessary because there are ways you can do it, but having an EHR that is interoperable and has these documents nicely curated is very, very important. Number two is the training and logistics that are required for these care coordinators. This is a RN who is not just focusing on providing care at the clinical level, but also has to be smart enough to understand the logistics and be trained to manage those logistics. Imagine the difficulty of taking oxygen to somebody's home in the middle of winter when you have close to 2 feet of snow on the ground to make sure that that care is not impacted. Or the necessary safety pieces that need to be put in place to make sure that your caregiver, the nurse, is safe, and so is the patient safe at that home. So there are huge elements from the social work standpoint, as well as the necessary background checks and the work that needs to be done from an assessment that is very, very critical. So that's the second piece. The third piece that I think is equally important is the way we go about payment and payment models for these. Our opinion is that these have to be risk-based models. Basically, there has to be a model that covers your hospitalization cost, and that cost could be covered comparison to the standard historical cost of an institution or the region or the nation. And you tie in an incentive from the standpoint of meeting quality metrics, safety metrics, and outcomes within that build. Now, the payment mechanisms could be done with approximately 2/3 of that cost on the front end and 1/3 of the cost or a percentage of the cost tied to quality and outcomes as a reconciliation subsequently. So those are the three things that I believe are the biggest challenges in terms of integrating care coordination and getting the appropriate improvement from the standpoint of hospitalization across the nation. Kendall, would you like to add anything to these points that I might have missed?
You're on mute, Kendall.
How about now?
No, it's great. We can hear you.
Great. So I think the one key important thing is this multidisciplinary team that Dr. Murley talks about is integrated and empowered through that telehealth kit. So because we are managing that patient through the 30 days, not only are we screening for eligibility, managing all of those social determinants in the patient's home and making sure that they're getting all of the acute care that they need. But then when that patient now is ready to be put back into their post-acute care,
Have we lost, or is it just me? We lost. Okay.
I think we lost her.
Yeah. Sorry, Kendall. If you could try again. Okay.
Kendall?
Oh.
Any better?
Yeah, no, we can hear you again. Sorry, we missed your last point that you were,
Yeah, just wanted to address that we're engaging that PCP with those vitals, the trending vitals of that telehealth kit that empowers the multidisciplinary team to manage that patient for that risk episode.
That's great. Thank you. Before I turn it over to the PTAC members for any follow-up questions, I do want to just check in with Kate. I don't know if you have any particular thoughts around this question, around specific activities that you think are critical to improving quality and reducing costs around care coordination.
Thank you for asking. I think, there have been a lot of really good points. I think what's really critical from our perspective is that there is coordination between specialists and primary care, and that the responsibility for that, especially in these models where primary care is taking on the risk of the patient, is that there's the ability for primary care to actually manage those patients well. So I think one of the biggest things that we see that is a barrier to care coordination, effective care coordination, especially in risk-based models, is that there's not widely available cost and quality data for specialists available for primary care physicians to use. And I know that's not quite exactly the answer to the question, but I do think that that's a really critical piece that we are continuing to think about in terms of how do we help primary care physicians really make the best decisions on where to send their patients so that they can effectively manage the care for their patients in those risk-based models.
That's great, thanks. And Joe, I want to give you an opportunity if you had some thoughts as you think about the palliative care model.
Okay, yeah, thank you. I'm not going to presume to talk for all the various populations, but when it comes to the serious illness population, one thing that's very clear is that the patient and family have to be partners in the plan of care that then drives the care you're coordinating. That it isn't enough to just be sure all the doctors are talking to each other or we have an updated medication list. For this seriously ill population, they often are receiving medications or treatments or interventions that are actually counterproductive to their goals or don't meet their preferences and values. So it's not enough to do a medication reconciliation. You actually have to look at those meds and say, do we have polypharmacy here? Are we using meds that the patients that are actually doing more harm than good? And that's where you see us in the palliative care world saying nothing's more important than anchoring this to that comprehensive assessment, that plan of care that actually is individualized and focuses on what matters most for that patient. I think that's more than just what we would call care coordination for the purposes of this discussion. And that's the reason that we think we need that additional palliative care boost for this population. Thanks.
Yeah, thanks. That's a very important point. So I'll open it now up to PTAC members. Any follow-up questions? Please raise your hand. Okay, I'm not seeing any. So, well, let's move on then. So next, I want to explore COVID-19 with its immediate disruption. With its immediate disruption in in-person care delivery and rapid expansion of telehealth. So how has the pandemic affected the evolution of care coordination, especially over the last 15 months? And have you had any recent experiences related to the pandemic or otherwise that have informed or extended your thinking on care coordination and how it relates to APMs? And finally, have there been specific lessons related to equity? So I'm going to start with Susan.
Thank you. I think everyone would agree that the emergency departments were at the epicenter of much of what happened during the pandemic. This included care for the patients who actually were symptomatic with the disease, those who thought they had the disease, those that needed testing, as well as the patients who could no longer access primary care for any number of reasons. Many of us who are involved in the building and the testing of this model, the AWESOME model, were struck by how the things that we put forth in the AWESOME model would have been and could have been critical in changing outcomes for patients. We routinely saw patients who would have normally been admitted to the hospital, but we no longer had capacity for, who we were then discharging with a pulse oximeter or without a pulse oximeter to families who didn't understand what to do, who couldn't access 911, and telling them to go home and isolate when they lived in a multi-family dwelling. This was especially true for many of the essential workers who continued to go to work or fed. We have to go to work. What do we do? So there were many ways that people were working to try to educate the population. But in fact, we were left with very few ways and very few places where we could transfer patients to. This included long-term care. So if I were to say I would have really appreciated a chance to have connections to folks in hospital at home, which would have been great, or FQHCs. We really, from a humanitarian perspective, it was probably the most difficult practice that our members and our doctors have had. How that speaks to this particular care coordination, I think, I pointed out a couple of those points, but I would like to leave my comments with the idea that we would like to be able to fill the gap. Again, we're going back to that quality chasm. There were patients that could have been admitted, should have been admitted, that weren't. We also learned a lot about who we could treat at home now and not admit. So there are going to be major changes in our current practice that will carry through. And the ability to take what we've learned in COVID-19 about the patients that were transferred home and did well would be, I think, a very valuable lesson and a way to study the impact of the care coordination. I know emergency departments did a lot of care coordinating. It was unreimbursed. There were some efforts at telehealth in some places. And that was looked, again, as a stopgap until primary care could assume care of the patient. So telehealth, this ability to care coordinate, it all came together for us in the urgent need to really focus on the types of things that we included in the AWESOME model of getting patients, bridging the gap to the other parts of the system where they can be provided care. Thank you. Yeah,
thanks, Susan. And I can certainly relate to that experience. I was in New York City, and when things back last March, it really was the emergency room where it was the epicenter, and we stood up just as you did. A lot of this care coordination, all the primary care offices were starting to close. Getting patients connected was really a struggle, and so it really was the ED that became the epicenter for doing a lot of this care coordination very quickly. That's great. Thanks, Susan. I'm going to turn to Kate.
Thanks. And I think, Susan and Paul both made really good points that I would like to echo, that, primary care did really suffer at the beginning of the pandemic. And, we believe that if our model, the APC-APM, had been widespread at the time of the pandemic with the prospective payments, primary care would have been a lot better off, because we've seen that the practices that received prospective payments and had that type of payment model really fared better than their counterparts that were strictly fee-for-service. They were able to adapt quicker to telehealth. And I think, COVID also exacerbated disparities for patients. So I think we're really at a juncture where there's a real opportunity to design payment models in a way that optimizes care coordination in an equitable way for patients wherever they are. And, when we think about that, we obviously want telehealth to be equitably available. We've talked about the broadband issues that in rural areas where folks don't have access. And so thinking about prospective payment models that allow for it, flexible care delivery, where they may be able to, use audio only to connect with those patients that might benefit from, virtual visits and those types of things, is really a way for innovative models to kind of move forward and move away from fee-for-service. The other point that I'd like to make is that access to these models is also an equity issue. So a lot of these models are tested regionally and have been tested in the same region for a long time. The APC-APM our goal was for that to be a national model. Obviously, that's not how CMMI tests things, and we understand that tests are limited in scope and scale for evaluation reasons. But when you think about kind of moving away and being more equitable, testing things in the same region over and over again doesn't really allow for innovation to foster in new places. And the other thing I wanted to say, just in terms of risk adjustment, because we haven't really talked about that a lot, but we did propose a risk adjustment based on social needs in our model to CMMI, and I think that has become a new and kind of an emerging thing with this new administration. They're very interested in equity, and so I think Andrew Bazemore and Bob Phillips had a Health Affairs article, blog post last week about it's exactly what we proposed to CMMI in terms of using social deprivation indices to risk adjust prospective payments to kind of provide resources to practices that are serving at-risk populations that they can then use to kind of provide holistic patient care. So I think I'll stop there.
Thanks, Kate. All great points. Appreciate it. I'm going to turn to Joe.
Yeah, thank you. Well, the COVID-19 pandemic certainly underscored the importance of palliative care. And it was not just to support the patients with serious illness and their families, but also the other healthcare professionals and teams involved in their management. For patients and families, the pandemic has added another layer of stress, more uncertainty, limitations on family visitation. So not just telehealth, we're doing televisitation, and disruptions in care. And on top of that, we've seen other healthcare professionals are turning to palliative care teams for support as they've had to grapple with uncomfortable new roles, maybe have goals of care and difficult conversations that they're not accustomed to having, or dealing with high mortality in their patient population. And we've really seen unprecedented levels of grief, moral distress, exhaustion, and burnout in general in our clinician workforce. And sometimes it's the palliative care team that's providing that support to the other carers. I would also echo Kate and other people's remarks about the importance of telehealth. There had been some experiments in telehealth and palliative care, but those were certainly radically accelerated when the pandemic hit. And those new telehealth flexibilities have made a difference and provided new tools to manage a patient's care. That's been especially important for the serious illness population who routinely have experienced difficulty accessing their care, even outside of a pandemic. Now with telehealth, we've been able to provide regular active engagement with patients throughout the public health emergency, a broader level of care coordination than we could have done before. And again, we can address not just their medical plan, but their psychosocial and spiritual needs, and engage with family members, caregivers, and coordinate with other members of the healthcare team. So telehealth has allowed care teams to undertake these care management and care coordination efforts more efficiently, particularly in rural areas. We often have to make home visits to check in on patients and assess ongoing needs. With telehealth, time and resources can be saved, and we can sometimes care for more patients in a more timely way because we're eliminating the travel burden. And telehealth can be critical to addressing urgent issues, as it allows for a rapid and timely response, especially for patients who may be isolated in rural areas. It's incredibly valuable to be able to conduct initial patient assessments in the home. And so there will always be a need for in-person visits, but we've really found telehealth has made such a difference in being able to meet people's needs when they can't leave their home or are even afraid to have clinicians visit their home because of the pandemic and risk of infection. So the paradigm of comprehensive assessment, I guess I'll sound like a broken record, sorry about that. Palliative care is deep, but the concepts are kind of simple. The paradigm of comprehensive assessment also supports equitable care. And I share that concern that as we see new tools like telehealth, we want to be sure that telehealth access is also equitable. So we do have to address issues around broadband internet, around the digital divide. But when it comes then to that personalized care, we find that how could you expect to have healthcare equity if you didn't base your care on a deep understanding of each individual's patient's preferences, needs, wishes, their psychosocial history, their spiritual and cultural needs, the social determinants and other determinants of health. If you don't start there, how could you ever hope to provide equitable care? So I would say again, these things are all converging, being flexible to meet needs during a pandemic, supporting equitable access to care. It all boils down again to finding all the ways we can to keep that patient front and center and build their care around what really matters to them. Thanks.
Great, thanks, Joe. Before turning it to the committee members, just wanted to check in with Narayana and Kendall, if you had any thoughts, particularly around this question. Certainly with COVID-19 hospital at home, I think we all would have liked to have hospital at home.
Yes, I am more than happy to share a couple things. I actually echo the sentiments that Kate and Joe shared, and I'll come to that. But I think what the pandemic did is it reinforced the value of care coordination as well as the hospital. So it allowed us to very rapidly deploy the ability to provide services at home, have the ability to isolate patients, and then use telehealth to track their outcomes so that as the vital signs started to deteriorate, if they needed adequate hospitalization with the ICU level care, we could do that. So that is something that was phenomenal as a consequence of the models that were put in place that helped us. So I do agree that that is extremely important. On the other hand, I think it is also important for me to touch on the compelling arguments that Kate as well as Joe are making related to the digital divide and equity. So if I think about Marshall Clinic Health System and the service area that we provide care in the most rural parts of Wisconsin, right? Roughly about 45,000 square miles. There are more cows than there are people, and you would not be able to access care without adequate broadband facilities. I have situations where, at least in the month of April, 12,000 of our care on the primary care side of it, appointments were all done by telephone audio visits. Some situations, I had patients actually use school parking lots to be able to do their televideo visits because of the expectations that were set up. And that was the case that I had shared with the Senate Finance Committee about the importance of focusing on the digital divide and investing on that because it's extremely important. So I echo the need to actually consider audio, consider that for risk adjustment, because if you don't do that, then you're really not creating models that will augment the ability. And equity is not just in terms of race. So for the poor, sicker, older patients who basically are spread and do not have the younger folks available to provide care for them. So all of those elements are extremely important. But the hospital at home actually allowed us to leverage it and do it appropriately.
That's great. Kendall, any additional comments on that?
No, I just echo what Dr. Marley said, and that, you know, we were actually able to really help facilitate the health systems in this time of burden. So where those were patients that definitely had to be in the hospital, they were able to get a room and have that ability, where patients that could go home could have that hospital level care in the home safely, still receive care rather than holding off on care, and then being managed appropriately by that care coordination and those telehealth kits.
That's great. I'm sorry, go ahead.
Yeah. Sorry, Paul, I just want to add one more point, which Kendall probably is touching up on. When remdesivir came into place, we were able to actually complete our hospital stays at home. So we were able to open up beds much faster to accommodate the parade of patients that were coming into the ER. So that was another functional element that this pandemic exposed about the weakness of our healthcare systems.
Yeah. Great, thank you. And Sherry and Christina, any comments on this question?
I can keep it brief, but yeah, just to add a couple of things. I think I want to agree with pretty much what everyone else said about the telehealth aspect of it. I think that was critical, and then Kate also mentioned audio only as a component really to help address some of the issues that particularly the Medicare population faced with, having access to appropriate technology to be able to do full telehealth visits. I think that was critically important, and it was in the relation to care coordination in our model more specifically. One of the aspects we have layered into it is this pre-consultation between the primary care practice and that specialty practice, and that can be an e-consultation. And in fact, one of the case studies we talk about in our paper is a 2001 study of an e-consultation intervention in a rheumatology practice, and it found that at least 4 of 10 patients didn't actually require a full rheumatology consultation in order to provide those patients with appropriate care. Some of those issues were rapidly resolved without having to have a visit with that specialist. So in other cases, the specialty consultation was made more efficient and effective because they had the information they needed and they knew what was happening when that patient came in the door. And I think that gets at the equity issue as well and addressing disparities, and that this type of an approach allows for ensuring that those visits are appropriate when they happen. And that also opens up the schedule a little bit more for the specialty practice, as well as, quite frankly, for the primary care practice if they're sure that they know what's happening with their patients with the specialty care practices. So it really does allow that access, whether it is via telehealth or an in-person visit or simply an e-consultation, that's able to address the issue. One other thing I'll mention that I don't think I heard so far, and that is the importance of all payer in this type of thing. And the reason why I bring that up in this context is Medicaid. I think we need to have more models that work across both Medicare and Medicaid to really get at addressing the needs of a broader population of individuals that really need services from both primary care as well as specialty care. And one other just little piece I'll mention too is that, Kate, I think it was you who mentioned the risk adjustment. I think that's really important, and I think we're talking about measures and maybe next a little bit, but I think we all recognize there are limitations within HCC coding within those scores for the measures themselves, and we really do need to evolve. And I'm going off of our model just a little bit, but we really do need to evolve to a place where we have better options, whether that's built into HCC or whether that's layered with it, to assessing the risk of patient populations and really taking into account the social drivers that they are facing. So I don't know, Christina, if you wanted to add anything to that.
Yeah, I'll just add briefly, I think because COVID brought many things to light, and especially the changing of everybody's social situations, whether folks lost jobs or, had to leave their dwellings. And so I think care coordination can really address social risks by utilizing some of the same mechanisms when it comes to care coordination with community-based organizations to be making those connections. And so I think there's really an importance that the model that we have addresses is capturing those social needs and utilizing that information, really knowing their patient populations and being able to connect to those community resources. And that was before COVID, but highlighted because of COVID, it will be afterwards. But I just wanted to say that, capturing and analyzing that information about the patients to directly connect to the community is very important.
Thanks, Christina. I appreciate that. That is very important. So just wanted to open it up to PTAC committee members for any follow-up questions. You can raise your hand if you have any. Okay. So if not, we're going to turn to the next question. So tell us where you see opportunities and facilitators for implementing and evaluating care coordination activities broadly. So what are some of the best practices, whether they relate to care delivery, payment mechanisms, measuring effectiveness, or addressing health equity challenges, and why? So Sherry, I know you started to speak to this a little bit. We're going to start with you.
Sure, thank you. And I want to reiterate what Christina talked about a little bit earlier when she discussed what's incorporated in the standards that we're asking the specialty practices to meet. I think that's a critical component here when we start to think about what are those best practices. I think those really lay them out quite well for the specialty practices in particular. With regard to sort of broader, how do we assess and what are the best measures? You know, in addition to those standards, we call for really using a robust set of quality and utilization measures, and I think that's critical for models. And I won't go into all the specifics of the measures that we talk about, but I think we can all recognize that those that that do exist are limited for a variety of different reasons. I mentioned the risk scoring component of it. I think there's variable validity data across different measures. I think that some of them are more applicable, obviously, to certain patient populations than others. And so the approach we took was really looking at our ACP Performance Measurement Committee takes on a very rigorous statistical and clinical validity review of measures, particularly focused on those used in internal medicine, both primary care as well as specialty care. And so we really focused on those for the purposes of this model, and particularly for testing it. And the other thing I would say about this is I think that we need to try to provide more on-ramps for practices to move from MIPS into alternative payment models like this. And so what we tried to do too was to think through how a structure of a model could be more aligned with what CMS is trying to do with the MVPs, the value pathways within the MIPS program, really trying to think through how could models and provide that sort of an on-ramp to really help them get to a place where they could more realistically take on the risk that's required to be an alternative payment model. We think that this combination of sort of these best practices, these standards, along with ensuring that the measures are as robust and applicable and useful as they can possibly be for the practices, is a way of better assessing how care coordination can be conducted. Additionally, you mentioned healthcare disparities. We talked about this a moment ago, so I don't know that I have much to add to what I said before, but I guess just to reiterate that, when a practice is able to ensure more appropriate, timely access to the right patients versus, and maybe some, through an e-consultation or through others seeing data up front, are able to determine they don't need that visit, or maybe they need something different. Maybe they need to go to a different specialist. That really does open up the opportunity for other individuals to have access to that practice and receive the care they need. And I think this is also particularly important relative to the recent pandemic, in that I think we have heard, I don't know if there's a lot of data out there yet, but that patients did delay care during this time. And so there's really an importance for ensuring this type of care coordination in the short term as fast as we can make this happen, because we need to have that care available to them and have it be accessible. Christina, I think you wanted to add on a few things too as well.
Thanks. Yeah, it was brought up before, but the access to data is so important. Having data liquidity and data sharing to facilitate the effective coordination of care across all settings, and also be able to give access to patients, families, and caregivers. And then Sherry mentioned about measures. We think a lot about measures, and we really feel, especially as part of the model, that there needs to be alignment of measures across different levels of accountability, but the data sources are different for clinical data for the clinician level, and then claims data for the plans. But like Sherry mentioned, the model focuses really on looking at measures around utilization and wanting to make sure that outcomes are the main focus. And then just lastly on disparities, the model emphasizes the importance of collecting and really knowing the patients that are coming to the office and what their needs are around cultural, language, and diversity needs, and making sure that the patient's care is adapted to that. And so both in primary care and specialty care, it's important to keep that in mind and making it equitable to all. So that's it.
Great, thanks, Christina. Narayana, I'm going to turn to you next.
Yeah, so Paul, I think from the standpoint of what is required, I think there are two critical elements. One is with respect to training of care coordinators, both with respect to the clinical and social assessments of the patients, as well as bringing the family into assessments. In addition, being required for some of the logistical pieces that are very, very critical in this piece. They need to have access to the EMR, get to know what the orders are, make sure that coordination is very well taken care of. The second piece is obviously our input in terms of risk-based global payments, because that will allow us to actually invest and achieve the results that are required in terms of improving outcomes and lowering cost of care. So those are two key criteria. In terms of the metrics, we use specific metrics that we track. I do not want to say that these are the only metrics that we should use, but I think these are the metrics that I think have significant value. One is the care coordinator communication. Make sure that a care plan is created and completed, and we track the number before the end of the acute phase episode and then before the end of the 30-day episode. Both are equally important. The third is to focus on tracking related to transition of those plans to the healthcare managers, so that each episode where the patient is handed off to the health plan managers are also taken into account. We focus on gaps in care, so the percentage of episodes of gaps in care that are checked and attempted to close any outstanding item before that 30-day period is complete. And we shoot for greater than 98%, and we're tracking at 100% for that at this point in time. Another important element is the PCP follow-up. We make sure that the appointments are not only just scheduled, but also attended within that 7-day period post-acute episodes. And the follow-up appointments are all appropriately scheduled and accounted for. You heard from Kendall how we share all of the vitals as well as the tracking metrics, so that the primary care physician knows precisely what happened during the hospital stay. And then we track the acceptance rate, because some of the acceptance rate is dependent on what the social determinants are, and also the deprivation index that Kate was alluding to earlier. And finally, completion of the advanced care plans. So when you have an older population greater than 65, you want to ensure that the advanced care plan as well as the surrogate and the decision makers are clearly documented. And documentation is available on the medical record for follow-up. It is easily locatable by the primary care physician, and then you make sure that the patient's wishes are managed. All of those elements are critical, and that needs to tie in with the day stay. So those are the metrics that I would probably use, but I wouldn't say that this is the a recovery care coordinator, and she's probably going to be far more eloquent than I am. So I'll shut up at this point.
That's great. You are fading in and out a little bit, and we don't want to miss any of your nuggets of knowledge. So just to let you know, we caught most of it, but so
sorry, Paul.
Sorry. No, that's okay. Sometimes the blurred background takes extra bandwidth.
My bad. My bad.
No, that's okay. Kendall, anything you want to add to that?
No, I think where Marley was going and that people might have missed a little bit is all those metrics that we hold those care coordinators to. So those key components that we make sure that we train the care coordinators up front, as Dr. Marley mentioned, but then we hold them accountable from that perspective. So making sure that they do those care plans, those advanced care planning with the patient, that they are communicating based off of those vital signs with those patients throughout that, they're setting up that PCP appointment within 7 days. All of those are key areas that we find that way you can have a successful 30-day episode and reduce those readmissions, just as we've discussed before. Without that, there's no way to really measure and track the effectiveness of the care coordination.
Great, thank you. Joe, I'm going to turn to you.
Yeah, thank you. I just want a couple of remarks about quality measurement, incentives, and payment to support care coordination. What you'd like to do, of course, is identify some associated quality outcomes that you would expect with good care coordination, and then incorporate them into a reasonable quality accountability structure. But that's actually been a little hard to do because there are substantial gaps in the current universe of quality measures that really matter for people with serious illness. In fact, most of the currently existing measures that are NQF endorsed and have been used for a while are process measures, and often they're capturing the processes of comprehensive assessment. The problem with process measures is that they can lend to a checkbox approach, done, not done, you don't know if it was done well, and that also can lead to them becoming topped out and a hard way to tell, good performers from poor performers. So what we hope is that we can move from process measures to something more like outcomes, patient experience of care, or utilization-related measures that get at the important things. We appreciate that actually the Academy's been able to get into a cooperative agreement with CMS to use some macro funds to develop a couple more measures that we hope will move us forward. These are patient-reported experience measures around being heard and understood or getting the help wanted with pain. We hope that'll move us forward. And we see now new measures coming down that are surveys, again, of the patient experience. What we've had before is that after someone dies in hospice, their caregiver is asked a few weeks later to report on their experience of care. But we haven't had surveys that get at the experience of care the person with serious illness is having themselves while they're still with us. So we see those coming. We see things like days at home coming. But I would say if we were just to look at concepts, the key concepts for the serious ill, we think, are the experience of care. The key outcome might be potentially preventable hospitalizations and more days at home. And another very important one is the timely and appropriate use of hospice care, because the purpose of APMs was not to in any way interfere with or undermine a really good comprehensive benefit we have for people who are eligible, hospice care for people in the last 6 months of life. And so we want to see appropriate utilization, not super short stays and not, people missing out on hospice because they're doing something else that's not been proven yet. One remark about payment is to recognize that care coordination and the deployment of palliative care teams might take an upfront investment from many practices that would participate. And so a payment structure that does provide adequate upfront payment is really important if we're going to give this a good test. We can't make it just about, some shared savings that you get years later after you finally had a final accountability. And so I think, we need adequate payment upfront. Usually that's something like a per patient per month kind of structure that really will support the palliative care team, the interdisciplinary team being available 24/7 to provide that comprehensive assessment and the care that flows from it. Thanks.
Great, thanks. So I'm going to move to the next question, which are, what are the major challenges or unanswered questions that you believe need to be addressed before the healthcare system can better incorporate and optimize care coordination in APMs and PFPMs? So Kate, I'm going to start with you.
Great, thanks, Paul. I think, first it's worth making the point that obviously all of the care coordination that happens in all of these types of varying settings is good. High risk transitions, high cost patients, patients with advanced specific diseases, but without kind of the basis of primary care centered population focused care coordination, I think it will fail to see improved outcomes, reduce costs, all of the things that we really want. So I think when we're thinking about making our healthcare system and care coordination really foundational in primary care, Sherry made a really good point about having an on-ramp and a continuum of care or a continuum of models available that really address and meet the level of risk that a practice is able to take on. So not overly burdening small practices with risk that is not a good business decision for them, and making sure that practices are able to deliver care and pay their staff and improve quality and outcomes, and not have to worry that that they might have money clawed back from them that is going to cause problems down the road. Another point I'd like to raise is around stability of models and kind of an off-ramp from models. I think we've seen with CPC Plus ending and primary care first being the next option that there are some challenges with designing models in boxes that don't talk to each other, because they're creating these financial cliffs that are really going to impact a practice's ability to deliver the care coordination that they've created this infrastructure to do. So I think that when we're thinking about long-term model development, we really need to think about both the beginning and the end of a test and what that looks like. And then the last piece I think I'll really touch on is that, especially for CMMI models, when we're talking about evaluation of those models, it's really challenging to understand the true outcome of a model because of all of the model overlap. So I think that when we're thinking about, we want more practices to move to value-based payment. We want, to move away from this fee-for-service system that doesn't serve patients or physicians or the healthcare system as a whole. The ability to effectively evaluate those models or to decide what deserves expansion or how those are tested is really something that we've been mulling over a lot. So I think that that's a big challenge, and if we don't address the challenge and the ability to expand these models nationwide, and really we're not creating an equitable system overall.
Great, thank you, Kate. Susan?
So even while we've been on the call today, patients have been accessing emergency care. Sometimes they call their primary care providers and are sent there for consultation, for access to tests, potential treatments. In some cases, it's just technology, a CT or an MRI that might not be available. Or they've had traumatic issues. They've fallen. They've had syncope, chest pain, abdominal pain. You can go through the list of undifferentiated symptoms that we provided a unique set of skills and services to the patients we treat. And our most difficult problem has been being recognized as part of the solution. I'll be very honest. Most of the measures today are how do you avoid emergency care. I, for one, have a $500 copay myself for going to the emergency department as of someone who gets their insurance on the exchange. There are many, many things that are in place to keep patients out, but not much on the back end after we've seen the patients. It's a 9-to-1 savings if we choose to discharge a patient safely to a home environment or to one of the systems we've heard about today, and to get in touch with people. And, like I think Bill talked about it earlier this morning, primary care practices that got rid of their answering machines and had people answer the phone, or timely access for us to access the kind of services our patients need after. So one of our challenges, and probably one of the largest challenges, has been being recognized again as part of the solution. And I think the PTAC was pretty verbal in suggesting that was a good idea last year, or 2 years ago we went through the process. And I think the second is understanding that what we're asking for is not a new payment model in general. It's just extending current payment models to be used in the emergency department. So care coordination fees, allowing us to use telehealth, which we have been using successfully during the COVID pandemic, giving us the opportunity to see a patient again, not by an emergency physician, if there's no one else available. It's Friday night and it's Sunday afternoon, to be able to re-examine a patient with abdominal pain rather than admitting them to the hospital. And all of those things that can not only generate cost savings, but don't take a major investment on behalf of payers or practices. More or less just it's the will, the political will and the policy will to integrate the kind of care that we provide into the system. From my perspective, for patient safety reasons, because we're very, very worried about our patients and the chasm between post-discharge emergency care and return to other parts of the healthcare system, but also for patient safety and just for the healthcare system in general. So again, thank you for asking the question, and I hope my responses were helpful.
Very helpful. Thanks, Susan. Joe?
Yes, thanks. I guess I'm going to just lean into kind of an elephant in the room for a second that we experience from palliative care, and that is all of this APM activity is being done with a mandate that it will be cost neutral or hopefully save the system money. But if you look at palliative care under traditional fee-for-service reimbursement, it is not adequately paid for. There are members of the interdisciplinary team providing vital, valuable services who can't bill the physician fee schedule, the social worker, the spiritual care provider, for example. And so we don't have the access we should have to palliative care in traditional payment structures because there hasn't been adequate reimbursement. So if you do an APM and you say, well, let's see if an APM around community-based palliative care can deliver better outcomes for less money, you're comparing it to a traditional fee-for-service system that actually is limited because it hasn't paid for it. And it sets a bar that's very hard to hit in terms of both showing value and achieving cost neutrality or cost savings. So, I know that's outside the bounds of what we can do today, but if I could pick one thing that would make a difference, it would be if you improve the care of patients, then let's test it. Let's not test it only if we can artificially try to show some sort of a cost saving when we're not capturing all the costs anyway. I guess I'll just make that my soapbox for today, and I appreciate the opportunity to say it. Thank you.
Thanks, Joe. Appreciate it. So we have about 8 minutes left, and before we wrap up our discussion with this panel, I'm going to ask one last question. The question is, are there any additional critical insights you would like to share about care coordination, APMs, and physician-focused payment models, the relationship between them, and potential for optimizing outcomes for patients and transforming value-based care? Before we get started, Jeff, can we go over a few minutes if the panel is available? Or should we end at 2:30?
If the panel is available, I would say, yeah.
Okay.
Go ahead.
Great. Okay. All right. Get a thumbs up. That'd be great. We'd really like to hear from everyone. So I'm going to start with Sherry.
Great, thanks. And I really just want to again state how much we appreciate the opportunity to share with all of you and with whoever out there is listening, our views on how we can better incorporate care coordination into alternative payment models. So one of the things I reflected on when I was thinking about this is I looked at what you all have in there as your definition of care coordination. And I think it's important to note there are a couple of aspects of it. You talk about deliberately organizing patient care activities, including the consideration of patient needs and preferences and timely communication. And I think this idea of deliberately organizing patient care activities and then figuring out how to layer that into a payment model is what's really important. And that includes what I know we, and it sounds like others have incorporated in theirs as well, incorporating the patient needs and preferences up front, in shared decision making and before the referral is made, and then actually throughout the time that care coordination is happening. And I think, deliberately incorporating those into whatever the attribution process is for this model is really important to get a true care coordination. And I wanted to emphasize that. And I think the other thing, there are a lot of practices that are really trying to do their best and do this, for their patient populations. And I think this is getting at what was mentioned earlier, there's not enough upfront investment for them to be able to do that. And so we need to find means such as the ideas that are being presented here to support that type of an effort. So that practices can build their own internal infrastructures. And I believe this can be done in sort of all different size practices to be able to provide, that type of care. And just reflecting back as well on the pandemic that we went through and how many practices really suffered great financial and mental strain without having any APM opportunities in their region. Particularly those that are on fully fee-for-service, it just re-emphasized all of the challenges that practices are facing out there, trying to sort of stay above water within a fee-for-service system. And just for a moment to also note, coming back to the challenges component, I think we do need more opportunities for these practices, and we need to figure out how, getting I think of what Joe was mentioning, we invest in those opportunities without, and we certainly obviously want to get to a place where there's savings or there's at least cost neutrality, but that's not an easy thing to get at when you're trying to invest in care coordination. It's not going to happen immediately. It really is down the road, and we need to think creatively about that and innovatively about that. And I feel like the PTAC has really looked very closely at a lot of these models, and I'm hopeful that this conversation is helpful as well. And so we can figure out how to get more of these off the ground. We need, as Kate mentioned earlier, we need to provide off-ramps and stability for those that have been in models, which has been more available to primary care practices rather than those outside of primary care. And we certainly are supportive of more for primary care as well, but there's just a limited amount available. And the other aspect I'll mention about it is that I think that we also need to think about how these models, and we talked about this earlier, can better be enabled to reduce health inequities. Again, something else that came up throughout the pandemic. And if there are ways that we can invest in these APMs and the performance measures that they're using so that they can try and assess other risk factors like housing, transportation, et cetera, that really affect the patient's abilities to adhere to the care plans that are being worked through with them and with their primary care physician and with their specialty practice. There's try to take that into account when it's being built out, but there are challenges that arise along the way. So I guess I just want to close by saying thank you for having us on here and appreciate the opportunity to share and are happy to answer any additional questions that the committee may have.
Thanks, Sherry. I'm going to turn to Kate.
Thanks. So I think I'd like to echo something that Joe said and something that Sherry said. I think the first is, we believe that fee-for-service has chronically undervalued primary care. So I think we would wholeheartedly agree with Joe's assessment that models that are built on fee-for-service, which is the majority of APMs available to primary care today, we're competing against a benchmark that's already too low in terms of cost savings. And so I think that is something that we are very cognizant of. And I think there's a lot of work to be done to really recognize the true value of primary care and to develop models that pay for primary care at the level that of care delivery that it's delivering. And the other thing I think I'd like to make is that payment reform really needs to precede care delivery reform. And so I think, the idea that there are these on-ramps and that there is a continuum and a transition, and that this allows practices to kind of move towards payment that better reflects the types of care they'd like to deliver to their patient population, that really meets the patient population's needs, is really necessary in payment reform in terms of providing these upfront investments in primary care are really critically necessary if we are going to see the types of outcomes we really expect from these types of models. So I think I'll end with that, and I want to echo Sherry's sentiments that I really appreciate you all the invite to sit on this panel and answer questions as they arise.
Great. Thanks, Kate. Narayana?
Paul, I want to start off by thanking the PTAC because our journey of the hospital at home began with the PTAC and has come a full circle after the pandemic. This program and subsequently CMMI and CMS have gone on to create the Acute Care Without Walls program during the pandemic. The pandemic itself has clarified that there is no place like home for recovery from the standpoint of hospital care. So that is very clear. If CMS could extend this program beyond the pandemic, that would be the number one piece to keep in mind. Number two, when CMS does that, there is also pressure on other health plans that have not adopted these plans, which can lower cost and improve value and actually improve patient experience. That is probably very, very important for us to recognize. Number three, there is a disconnect between where home health resides in terms of care.
Merrily, we're having a hard time hearing.
Oops. Let me do one thing.
Yeah, maybe Paul, while he's re-upping, why don't you go to your next panelist and then come back to Merrily?
Sure. Susan?
Sure. I'd like to echo, to really reflect back on those last comments, because the journey with the PTAC process really has generated a great deal of knowledge and innovation in our own specialty. Quality and cost were siloed prior to the development of the PTAC model. They were in different committees. They didn't really meet. They were thought of differently. Reimbursement was one thing and quality was another, and quality measures were another. And this brought us all together. And in developing and looking at the data about what happened after patients left the emergency department, we learned a great deal about variations in practice, post-discharge, what happens to patients. We generally don't know when we send someone home what happens. So we learned a lot more, including the fact that sometimes 20% of Medicare patients with acute conditions like chest pain never see anyone within 30 days. And these are fee-for-service Medicare patients. These are not the uninsured. We were looking specifically at Medicare data. So we found gaps there. This informed our COVID care, because we had been talking about all of these ways that we can improve care coordination. It certainly is feeding into our development of an MVP as a bridge for those of our members that are in MIPS and that are trying to get to the APM model. And so that our MIPS, our MVP proposal that has gone to CMS really does focus on these undifferentiated conditions. And that would have never happened without the data that we put together during the PTAC process. And we certainly learned a lot more about inequities. We've always known they were there, but when we started to look at the variation at both regional and facilities, the idea that the social determinants of health have such a profound impact on our practice of sending patients home, it was something that we knew, but weren't able to quantify. So all of those have been benefits, and I really encourage those that are thinking of submitting, or even those of us who've already submitted, to consider perhaps thinking about how you might do it with some of the information you garnered today. And I'll close by saying I still think the biggest challenge is that until CMS integrates some of the things we learned and some of the items that are included in our alternative payment model proposal that has gone to CMMI, it's going to be very difficult for us to impact any of those other things I mentioned. This has been a driver for us, and in order for us to be able to do that, there needs to be a payment reform, and it always starts with CMS, and then the private payers follow. We have been in conversations with private payers, including Medicare Advantage plans, for over 2 years, and they're all waiting to see what happens at CMS, as are we. And we're more than willing to also work with anybody here on the call and who has, or others that are in the audience, who would be interested in how you can drive cost savings in your models through coordinating post-discharge ED care with us. So thank you.
Great, thanks, Susan. And Joe, you may get the last word.
Okay, yeah, we'll see. Well, first of all, I absolutely want to thank PTAC first for hearing our proposal a few years ago and even recommending it, for all that we've learned from going through that process, and for opening a door for our ongoing engagement with CMMI on a number of different models. It's been a great process, and thanks for inviting us back for this really great discussion. I would say that if we, based on this idea that traditional fee-for-service really doesn't have a mechanism to support community-based palliative care, and yet that has been shown to provide great benefits to people with serious illness, who are a population that have high risk and high needs and often receive low value care. Given that, we really need to see a demo of community-based palliative care. And, we're happy to see that palliative care is included now in some other models, such as the Medicare Advantage VBID model that's being tested. And we had hope that we would see the serious illness population model tested within primary care first. But as I'm sure you all know, that's on an indefinite hold right now. And I would say when push comes to shove, we probably ought to be testing 2 or 3 different models of palliative care simultaneously. It's clearly part of the value solution. And we can't wait because the traditional fee-for-service world is not supporting it for our patients. But thanks so much for having us back. This was a fantastic experience. We appreciate it.
Thanks, Joe. Appreciate it. And I know we went over a little bit. I appreciate the panel staying on. I'll just ask the PTAC members if they have any questions that they want to ask before we close this session. Okay, not seeing any. On behalf of the committee and our audience, I would like to thank each of our panelists for their really tremendous insights today. We're absolutely grateful that you've been so generous with your time and sharing your expertise. So, Jeff, are we going to take a short break or?
Yeah, I think we should take a 10-minute break, given, we probably, why don't we do it at, get back at 1:45?
Yeah, okay.
Try that.
Great. So we will take a short break and reconvene at 2:45. Please come back. PTAC will be taking public comments and then discussing all of what we've heard today to prepare for a report to the Secretary on care coordination and then releasing an RFI to get even more public input on today's topic. So thank you, everyone.
Thank you, everyone.
Produced by the U.S. Department of Health and Human Services.